everybody. I am Aaysha, and I was a resident not long time ago, maybe just one month ago. I was sitting on the other side, but I'd like to talk about a topic which I saw as a resident a lot, and I always think it's a challenge as a resident to see the patient in the ER, and by the time you call gastroenterology, a lot of damage is already done if you don't take care of certain things well in time. So let's start with acute pancreatitis. First few slides are a little boring, just to let you know, but I wanted to go over them since they are important. I have no disclosures. Okay. Why are we talking about it? Why are we talking about pancreatitis? Because $2.6 billion are spent every year on these admissions and discharges of acute pancreatitis, which is a lot of money. And what's going on in the recent past, that our hospital admissions have gone up from 40 per 100,000 to 70 per 100,000 in the last few years. And the fatality rate is not affected, but mortality and morbidity is still high. So this is pretty important that we are aware of it. This is a mnemonic I always used in my USMLE days and my medical school days, where I needed to know what is the etiology of pancreatitis. So it's kind of a way to remember it. I get smashed. So in case you wanna guys Google it, it's pretty much there everywhere. Okay, so etiology. First of all, gallstones are the most common cause of acute pancreatitis. And the way you're gonna figure it out once you see the patient in the ER is that their ALT levels are more than 3 times the upper limit of normal. That has a high positive predictive value. So if you see an ALT that high, think about gallstone pancreatitis instead of jumping onto any other differentials on your diagnoses. There is no role of other markers to kind of distinguish between them. And one very important concept which we need to know as an internist is that if somebody comes in with gallstone pancreatitis, they should have a cholecystectomy before they go home. It is a very important board question, concept, and in real practice as well. So make sure they get the gallbladder out before they go home. Okay, so next is alcohol. This is the second most, actually alcohol is another second most common cause of pancreatitis. Don't expect to see acute pancreatitis on a person who just binges in and has been drinking alcohol for less than 5 years. That is probably a too over-enthusiastic approach to diagnose acute pancreatitis on him. Anybody who has damage for more than 5 years with alcohol to his pancreas and has been using more than 50 grams a day, which is not a lot of alcohol, think about alcohol-induced pancreatitis in that set of population. Secondly, these people, not all alcoholic pancreatitis will change to chronic pancreatitis. This is a really important concept. So don't expect if somebody is having recurrent pancreatitis because of alcohol, they will be having chronic pancreatitis. It doesn't happen that way. Second is biliary sludge microlithiasis. This we will see in our practice a lot more, the first 3 things which we talked about. So what happens here is anybody who is in the ICU for a long time, they've been getting TPN. Rocephin is a very common etiology. Actually, the first case I saw in my residency in VA, he got ceftriaxone and he landed up in acute pancreatitis. So don't ignore it. It's a pretty common etiology you will see. Anybody who's been fasting for a long time, what happens is that the bile is going to get crystallized into less than 5 mm stones and actually is a relatively common cause of pancreatitis. And you will say idiopathic in those patients, but look for a cause. You might find it. Okay. Next is hypertriglyceridemia. Pancreatitis is the 3rd most common cause. We'll talk about it in detail next as we go forward. So triglycerides more than 1,000. Think about it as a differential. It's very important. If you don't find gallstones, if you don't find alcohol, this is the 3rd most common cause, hypertriglyceridemia pancreatitis. We'll talk about again. Next, post-ERCP. I think this is a very important concept I need to discuss here. You will come across a lot of patients who will have ERCP. They will get it done in JCMC, they will go to VA, and you will be on your ward service monitoring them. Please don't check their enzymes if they are asymptomatic. Because most of these patients have hyperamylasemia. Their amylase levels will be elevated in more than 70% of the patients. So don't check them till they are symptomatic. If they have abdominal pain, nausea, they are presenting with symptoms of acute pancreatitis, please be aggressive and pursue it. But just don't check enzymes because you just want to do some lab work. Don't do that. That actually incites a lot of unnecessary workup. We don't need it. And actually, the ECG guidelines recommend giving rectal NSAIDs, ibuprofen, and endomethacin to be given rectally in people who are high risk of post-ERCP pancreatitis. Okay, so this is a busy slide, but I don't want to kind of waste time here because we have more stuff to discuss up front. So the drugs, they can cause pancreatitis. Most of the drugs have their own physiology to incite trauma to the pancreas. I won't go into the details, but you should be aware of the drugs which cause pancreatitis. Then next one is pancreatobiliary tumors. Anybody who's more than 40 and is coming into you to see you with multiple episodes of pancreatitis, please think about some pancreatic tumor. But if somebody is less than 40, then probably think about this, like idiopathic causes, some genetic causes. I'm not going to go into its detail. So I think we are good. I think you can have your clickers ready. From here, we start with 8 questions. And those 8 questions are the 8 difficulties, the situations I've had in my residency. And I want to talk about it. All right. So the question is, which of the following is acute pancreatitis? First one, 47-year-old male who has epigastric abdominal pain. His lipase is elevated, but his ultrasound is unremarkable. Next is 67-year-old male with the left upper quadrant constant pain. He has normal amylase and lipase, and his ultrasound abdomen shows increase in pancreatic volume. Next is 35-year-old male, epigastric pain, increased lipase, and has pancreatic necrosis, all 3 of them. Then next is 21-year-old female, epigastric pain radiating to back. Lipase is normal, but CT abdomen shows peripancreatic fluid collection. And last of all of the above. All right. Okay, we have 32 responses. We'll move forward. Okay, excellent. So we do have some confusion here. So I'm glad some people have confusion because that's what I'm here for, to clear the concept. Okay, so the answer is E, all of the above. Okay, so what are the criteria to diagnose acute pancreatitis? First of all, out of all these 3 criteria, you only need 2. You don't need all 3 of them. So be very important when you're clinically assessing a pancreatitis patient in the ER. Number 1, he may just have abdominal pain, but make sure his abdominal pain is in the epigastric area in the left upper quadrant and it's going to his back. So characteristic pain. If he's having left lower quadrant pain or suprapubic pain, it's not pancreatic pain. Number 2, his amylase and lipase are 3 times the upper limit of normal. Lipase is a more sensitive test. So this is another diagnostic criteria, but don't be fooled with it. You will come across various situations where lipase and amylase are elevated, but the etiology is not pancreas. So keep your mind open. It should go with your entire picture of the patient presentation. Next is characteristic findings from abdominal imaging. So you need to have 2 out of 3 to diagnose acute pancreatitis. What we had in all these patients, all of them had at least 2 and one of them had all three. So I was just trying to confuse you, but just be careful when you are diagnosing pancreatitis. All right, are you guys ready with the next question? So next is, this is a very important question. This concept I think is very, very important. So 60-year-old male with a past medical history of hyperlipidemia, uncontrolled diabetes, is seen in the ER. He has epigastric abdominal pain. His lipase is 2000. After initial resuscitation, what is the imaging study of choice you're going to give to this patient? First is you're going to give him contrast-enhanced CT, MRI abdomen without a contrast. You will do MRCP, ultrasound abdomen, or you'll go for ERCP. All right, I think I'll move forward. All right, excellent. So the answer is ultrasound abdomen. I did try to confuse you with CT, and actually that is the truth. You will come across a patient in the ER. They've already given CT with contrast, and then you are dealing with its complication as an internist, admitting the patient to the ICU and dealing with all that stuff which comes with it. So my entire presentation is based mainly on ECG guidelines. These are the latest guidelines, 2013 October, and they are actually really, really useful. So they recommend transabdominal ultrasound as the preferred modality of initial imaging study, because the most common reason, as we studied in etiology, was the gallstone. So first rule out gallstone. You don't do CT once the patient is in the ER. That is absolutely wrong. Never do it. You will see your ER attending will give you a call and they'll say, I ordered a CT scan and please come and see the patient has pancreatitis. I'm not trying to be mean, but I have cancelled CT scans so many times as soon as I knew I'm going to see an acute pancreatitis patient. I can always order it if I need it, but in the first 48 hours, you are insulting his pancreas, his kidneys all the more, which is the last thing you want to do. So CT scan, when is it done? It is done 48 to 72 hours after the patient is in the hospital, continues to have pain, has fever, has nausea, and is no longer able to eat anything despite 48 hours of resuscitation. So keep this in mind. This concept is super duper important. Next is MRI. This is another option if somebody has renal insufficiency, has contrast allergy. We cannot do CT, we'll go for MRI. But we have to do it without the contrast. So that's another option. But please focus, abdomen ultrasound is super duper important. It's the initial study. All right, so next question. All right, so 63-year-old woman in the ED is seen. She has abdominal pain in the epigastric area radiating to the back. Patient is nauseated. She's anorexic, tachypneic, and moderate distress. So she's a sick patient. Her temperature is 104. Blood pressure is high. She's tachycardic. She's tachypneic. Abdomen is distended, and there is tenderness with palpation in the epigastric area. There are no masses or no peritoneal signs noted at this point. Her hemoglobin is 15. Her hematocrit is 60%. WBC count is high. Her amylase and lipase are through the roof. You do contrast, the contrast enhanced CT is already done. And you see that there is a pancreatic edema in the pancreatic and the peripancreatic area. No evidence of necrosis. And what is the most accurate test you're going to pick in this presentation of the patient, which indicates this patient is having a really bad clinical course, that she's a sick patient? What is the indicator? Number one, it's the lipase. Number two, hematocrit. Next is CT findings of peripancreatic edema, or she's having a temperature of more than 102. This is the question I've modified from MKSAP. You'll find a similar question in MKSAP. The concept is almost same. I'll talk about it. All right. All right. Very good. The answer is B. So CT findings don't give you the severity, nor does the temperature. So, I mean, the temperature does, but it's not the best criteria to figure out the prognostic indicator in this patient. So before this, there were like Apache score, and there were so many other scores which we were reading in our medical school. They were asking us to do it, but they're not practical. You can't keep doing it. You have to wait for some time. Either you do it in the ER, or then you have to keep waiting it, following it, which does not make sense that much, and the guidelines are moving away from it. So they want you to pay attention to these common lab values, common scenarios, so that you can identify a sicker patient and put him in the ICU as soon as you can. So there are 4 main categories under which they want you to be careful about. So first is the radiological features. Somebody has pleural effusions, pulmonary infiltrates. Probably they are indicating towards ARDS, acute respiratory distress syndrome, because these people ultimately will land in ARDS if they're super sick. And maybe if there are a lot of pancreatic collections, necrosis, fluids around it. Lab findings, this is where my question came from, and the MKSAP actually highlights BUN more than 20. So this is very important, very handy. If somebody has a high BUN more than 20, or somebody's been in the hospital and their BUN is actually going up despite you are doing everything, it means something else is going on. So that is a bad prognostic sign. So rising BUN, rising hematocrit more than 44%, elevated creatinine, these are bad markers. We are dealing with a sick patient here. I think one of my slides is missing, but that said that somebody who has SIRS symptoms, all the 4 criteria for the SIRS, so that is very important, don't miss that. That is also another criteria to kind of watch on for. So this is the revised, please. Yes, actually what happens is when you see these patients, just like a DKA patient, when he hits the ER, he's already is in a lot of fluid deficit, maybe 10 to 12 liters. So this patient, they're also in fluid deficit. So they are totally hemoconcentrated. There is a lot of actually reasoning to it. They say people have been nauseous, they have not been eating well, they have been dry. As a result, they land in hemoconcentration. And the sicker they are, their oral intake is going to be less and less. As a result, you will see very high hematocrits, creatinines, BUNs. So that kind of indicates how dry he is. Make sense? All right, so this is the classification which probably it's a good idea to know, because you will be writing in your assessment and plan. You can't say you can't say just acute pancreatitis to anyone. You should know if it's a mild acute pancreatitis, moderately severe, or severe, because that kind of helps us send the patient to either floor or to ICU, or keep a close eye on him or not to keep a close eye on him. So mild acute pancreatitis is like probably a relatively stable patient, doesn't have much of the organ failure going on. He's just there for pain, and you treat him, he gets better. Next is moderately severe. These people are relatively sick. They can present with organ failure, but they recover within 48 hours. So that is moderately severe. Severe acute pancreatitis people are with persistent organ failure. Despite 48 hours of resuscitation, they are not getting better. So that is a severe acute pancreatitis. This is just to kind of know, because your attending might ask you what kind of acute pancreatitis does he have. So it's good to know. All right, so next question. Okay, this is an interesting question. This is a little hard one, but I really want you guys to know about it because it's important. Okay, so this is your first month of internship, and you've been called to see a 45-year-old male in the ER. His past medical history is significant for alcohol abuse. He comes with severe abdominal pain. He's tachypneic, tachycardic, very dry oral mucosa and skin. His weight is 60 kg. As you enter into his room, his normal saline is running at 100 cc per hour. His sodium is high, potassium is 3.2. His chloride is high, BUN is 40. His calcium is 8.1, creat of 3, and hematocrit is 66. So he is actually very dry. Your senior has to actually run to attend code blue, and he asks you to give him ample of fluid. Okay, so I'm going to give you options. So how much fluid are you going to give? So you give 20 ml per kg IV over first 30 minutes, followed by 3 ml per kg for 8 to 12 hours. I've just changed everything, but that's most of the numbers. All right, so let's move forward. Okay, so the answer is A. This is probably a trick question, but this is exactly from up to date. You should know this number by heart, because what happens is you think that probably you guys have now you have overhydrated in your multiple choice question, but in real world you will see that people don't get enough fluids, they get sick, and they go down the spiral. I have actually seen one patient die of acute pancreatitis in today's world because we didn't resuscitate him enough. So we should not do this mistake, at least that's my moral from this question. So you give 20 ml per kg over the first 30 minutes, and then you give 3 kg per hour for 8 to 12 hours. Please learn this number. You can refer to up to date for its reference. So basically, the logic is you're going to give about 10-ish liters of fluid in the next 12 hours, depending on what the patient's weight is. About 7 to 10 liters is the average you will end up giving to a patient in the first 12 hours. It's very important. Number 2 concept. Lactated ringer is actually a preferred solution over normal saline, except if somebody has hypercalcemia. Hypercalcemia-induced pancreatitis, that is the only contraindication to give lactated ringer, but otherwise, please give it. Lactated ringer is the preferred choice. Why? Because you will end up giving about 10 liters of normal saline, and you will actually push the patient into non-anion gap hyperchloremic metabolic acidosis. So be very careful. Although people say it doesn't matter and all that stuff, but this is what the guidelines say, and prefer to use this. And just make sure the overall picture of the patient, if somebody has renal failure, is on dialysis, or somebody has heart failure, don't go too aggressive. There are always caveats in medicine. Nothing is 100%. So just look at the overall picture. So for the first 12 to 24 hours, aggressive hydration is very important. After that, not that important. Reassess the fluid interval, how much fluid you're going to give every 6 hours, because you have to keep deciding if you have to give more fluid, less fluid, depending on how the patient does. And what is our goal? As we discussed in the lab values, high BUN, high CRET, and high hematocrit, this is what we want to kind of look at. It should normalize. It means you are doing the right thing, okay? So that's all about it. Then the next concept. Okay, so next question is, 37-year-old female with a past medical history of diabetes. She's admitted to the hospital with abdominal pain for the last 4 hours. She has a temperature of 102, respiration, she's tachypneic, tachycardic, her triglycerides are 6,000. Her blood glucose is 200, not that bad at all. Lipase and amylase are high. Ultrasound was done and it shows pancreatic necrosis. She's getting ample of fluids. We gave morphine for pain. And actually you can just, probably it's 3 hours, you can say it's 9 hours away. You cannot send the patient to the dialysis center somehow. So what is the best modality of treatment you're going to offer to this patient? You start heparin, you give insulin and dextrose, you transfer the patient to the dialysis center for apheresis, and you start atorvastatin, fenofibrate, and gemfibrozil. All right. All right, excellent. So B is the right answer. So what is the concept behind it? So we'll talk about it. So hypertriglyceridemia pancreatitis, you will actually come across 1 or 2 cases in your entire residency. At least I have seen 3 of them. And one of the patient I saw in VA ICU, we could not send him for apheresis because it was a weekend, just like this patient. And we had to manage him on a drip of insulin and dextrose because his blood glucose was not high. So we'll talk about it. So basically in hypertriglyceridemia, if you see a relatively, I won't say a younger patient, but you will see a patient who has been struggling all his life with his triglycerides, think about familial conditions and probably refer them to an like endocrinologist once they have once they are stable and they're ready for discharge. Secondary causes of hypertriglyceridemia, you will see poorly controlled diabetes, alcoholism, somebody's on hormonal therapy. I would like to highlight here protease inhibitors because this is probably an important concept to know. They induce metabolic syndrome, cause dyslipidemia, and they also cause hypertriglyceridemia, which I'm seeing actually in my clinic these days. So if somebody has a triglyceride more than 500, they are at an increased risk, but more than 1,000, they definitely have a very high risk of landing into this pancreatitis. Up to date says the first modality is apheresis. If somebody has triglycerides more than 1,000, their lipase is more than 3 times the upper limit of normal, and they are suffering from lactic acidosis, organ failure, please go for apheresis. But practically it's not possible most of the time, which I've seen in my residency. So what we do is, there are 2 situations. If somebody comes in with uncontrolled diabetes, you can actually solve 2 problems with just one thing, insulin. So if somebody's blood glucose is more than 500, let's give them insulin drip. And this is the rate 0.1 to 0.3. This will actually help bring their glucose down. This will also help us get their triglycerides down. The logic, why do we use it? Because they say that it inhibits the lipase enzyme, which actually is causing the lipase in the presence. Actually, I'll tell you. So lipase breaks triglycerides into free fatty acids, and free fatty acids, they cause inciting injury to the pancreas, causing acute pancreatitis. So when we give insulin, it inhibits lipase. As a result, those free fatty acids or the radicals are not formed, thus no injury to the pancreas and no acute pancreatitis. So that's the entire logic of giving insulin. But if somebody's blood glucose is between 150 to 200, and you give insulin, you don't want to land them in hypoglycemia. So it's okay, give them 5% dextrose with the insulin. It'll probably help us bring the triglycerides down. So that helps. But there are 2-3 things you have to monitor. Check their blood glucose every 1 hour. You probably need these patients to be in the ICU, and tell the nurse to check blood glucose every 1 hour so that they don't bottom down on you. Triglycerides should be checked every 12 to 24 hours, and stop the insulin once it's less than 500. So that's very important. And once they are done, as we know, we have to start them on diet, give them a fat-free, simple sugar diet, and discharge them on gemfibrozil BID, plus an endocrinology referral if they are having familial issues. So that's how you manage these patients. All right, so I'm going to go to my next concept. And the next concept is an important board question as well, which is there in USMLE World. That's where I've kind of taken help from. All right. So this is the same patient. After 48 hours of aggressive fluid resuscitation, the patient continues to have low urine output. She has bilateral infiltrates and has developed severe metabolic and respiratory acidosis. We had to intubate her. Over the next 24 hours, her urine output is only 30 cc. The abdomen is very distended. And same, we are like a poor intern at 1 a.m. and the nurse calls you in the middle of the night and expresses her concern. So what will you say? You can say it's okay, it'll get better by tomorrow. Tell her call nephrology, consult stat because probably patient is having renal failure and decreased urine output. Next, ask her to check the intravesical pressure and there's a typo and call with the results. Next is ask her to put a Foley catheter because the patient could be having post-obstructive renal failure and leading to obstruction and retention of urine. And this is actually a true case I saw in Holston Valley Hospital. All right, we have 30 responses, so we'll move forward. All right, excellent. So the answer is C. Okay, so what's going on with this patient? Let's see. Okay, so this patient has something known as abdominal compartment syndrome. If you might have read it in your USMLE days, but you will see these patients in real life soon. So this is the way they check the intravesical pressure. The Foley is actually clamped here. Yeah, so they clamp it. And then in this port, they are going to put 60 cc of fluid in the bladder, and they are going to connect the needle of the transducer to check the pressure. So this is how they normally check it. We need not worry about it, but I just wanted to show you. All right, so what's going on? Let me show you this slide first. So normally the pressure is less than 10, where you don't worry about it at all. When it gets more than 10, it is something known as intra-abdominal hypertension, just like we have essential hypertension. This is intra-abdominal hypertension. When it gets more than 20, we start to worry about it. And at more than 25, it's a surgical emergency. You have to get surgery on board like stat, even though it's in the middle of the night. And that's what was happening to our patient. So I'll just go through the quick things here. We've talked about that if pressure is more than 20, there is a chance this patient is going to have organ dysfunction, and various organs are affected. I'll show you the slides. What kind of patients you will see in somebody who has abdominal surgery, AAA repair, burns patient, liver transplant, anybody who's had abdominal intervention, or like our patient who got bunch of fluid and they are not moving the fluid, it's getting third spaced in their abdomen, so they are having distended abdomen. How will these patients present? So they will have distended abdomen, their renal flow is going to decrease. As a result, their urine output is going to be low. So that's the thing you're going to hear from the nurses, that the patient has peed 30 cc in the last 24 hours. So be very alert and vigilant for it. It's important. And then their ventilatory requirements are going to go up. And they are going to turn up the ventilator each time. And if you have such a situation, this should be on your differential, abdominal compartment syndrome. So I've already showed you how we check the intravesical pressure. And at 25 of pressure, surgical decompression, you have to get it done. All right, so this is a slide from UpToDate, which kind of helps us figure out what happens when the abdominal pressure goes up. I don't want to kind of bore you with this entire concept, but pretty simple here it is. Once the pressure is going to go high, your cerebral perfusion is going to go down, your cardiac output is going down, your intrathoracic pressure is going to go up, and your ventilatory requirements will go up. Your GI flow of the blood will go down, your renal flow will go down. As a result, you're having low urine output. You're going to have decreased blood flow to your liver. As a result, you will see a lot of lactate accumulation. So you will see lactic acidosis in these people. And obviously, their belly is so tense that you will see this rectus sheath blood flow. So their belly is going to be like really distended, about to get burst or something. All right. So I have next question. All right. There is one more question. These are the only concepts I wanted to discuss regarding pancreatitis. So next is 47-year-old man who you're seeing in the ICU for acute pancreatitis, and he continues to have abdominal pain despite getting 7 days of treatment. Each time you start him on a diet, his pain worsens. Now, after 7 days, you do a CT scan, as we discussed before, that we did ultrasound before, and after 7 days of doing everything, nothing is working out. You do a CT scan, and you see at the tail of the pancreas a 6 centimeter fluid-filled necrotic cyst. So what would you do next? You do a CT-guided FNA. You empirically start the patient on meropenem. You start on meropenem or fluconazole, and then you consult a GI, stat. So this is a trick question. All right, I think we're with 30 responses, so we'll move forward. Okay, so the answer is A. I know we do it very often. We put the patients on meropenem and we think we are doing the right thing, but no, it's not right. Unfortunately, the guidelines don't recommending starting antibiotics on a patient who does not have actual infection. You have to culture prove it. I know it sounds really funny, but I'll show you something. Okay, so this is actually from ECG Guidelines. They say if you're suspecting infection, please do CT-FNA. Get the fluid out so that you have a proof that somebody is having infection. Start them on antibiotics, and then you can tailor your antibiotic, stop the antibiotic, or continue it depending on what the cultures show. This is all this slide was talking about. Secondly, if you cannot have CT-guided FNA, but you think this patient is really septic, he's having fever, chills, get his blood cultures and put him on empirically on the medicine. Okay? But the logic is why this question was wrong, why it's not meropenem, because you did not collect blood cultures in this patient, you did not have any evidence to prove he's having infection. Empirically starting antibiotics is no longer an accepted concept. So I'll just revise this real quick. So basically, if you're suspecting necrosis, obtain a CT-guided FNA, and if the culture is positive, it's infected, or if you think the patient is really sick, collect blood cultures, and you think it's infected, in a clinically stable patient, you observe, it's more of a conservative management. You keep monitoring them closely with CTs and everything. But if patient is unstable, please get surgery stat to come and do the debridement. Very important concept. On the other hand, if you did a CT-guided FNA and the gram stain was negative, you started them on antibiotic, DC them, and just give them supportive care. And that's what all they need. So be very careful. This concept is very, very important. Yes? Mm-hmm.
What you did as the cutoff was 30% necrosis on CT. Greater than that, you go for surgery. Less than that, you put them on medical management. You're saying that is...
That is outdated. If you look at the ACG guidelines, that's what they are recommended. That was what you're talking about, 30% was probably many years ago. Even I have read that. Even on your USMLE days, you read that. But now it's no longer accepted, unfortunately. So what they're saying is that we need to, the routine use of prophylactic antibiotics is not recommended. And they say that if there is a sterile necrosis and you're just trying to prevent infection to a sterile collection of fluid, that is also not recommended. And that's what we have been doing so far, but that's the new one. Next, these concepts we have discussed. If somebody has initial CT scan, collect a gram stain culture, and then decide your antibiotics. And then next is, if you can't do FNA, collect blood cultures and everything, and then decide your antibiotics. So that's mostly it. That's mostly the table which they're talking about. All right. So next is they're saying what kind of antibiotics we need to use. As you guys have already recognized, we need to give carbapenems, we need to give quinolones and flagyl. These are the 3 antibiotics which will actually penetrate and actually help with help preventing the infection. And they have been shown to decrease the mortality and morbidity. So it's okay to use, but in certain situations. Then antifungals, big no-no. You don't give antifungals. This is totally outdated. You don't routinely administer antifungals to a patient who you are suspecting he's having necrosis. So that's also not recommended. All right, so my last concept. All right, so 56-year-old man is admitted with pancreatitis. He does not have nausea or vomiting. His abdominal pain is resolving. His lipase is 2200. His ultrasound shows pancreatic inflammation. And what statement here is correct regarding his diet? Now, this is also a confusing concept. I'm just trying to clear some air around this concept. Start a low-fat diet immediately after the abdominal pain resolves. Start a liquid diet once lipase normalizes. Start a low-fat diet once pancreatic inflammation normalizes on the ultrasound. Or start a parenteral, total parenteral nutrition. I'm glad nobody is sleeping. That was my worst fear, that people are going to sleep during my presentation. All right, I think we have 31 responses. 32, okay. All right, excellent, very good. So the answer is A. Okay, so I'm just trying to clear some concept here because there is always a confusion regarding initiation of diet. So if somebody has mild acute pancreatitis, who just walks in with abdominal pain, is doing okay, and they are not even nauseous, not throwing up, start them on an oral diet. It's perfectly fine to start it. Don't delay that you have to give rest to pancreas. That is a very, very conventional concept, no longer accepted. There is no need to give rest to pancreas or to the gut. That is no longer the right concept. And there is no difference in the diet between low-fat solid diet or the clear liquid diet. In fact, they are promoting to start on low-fat solid diet instead of giving a clear liquid diet and then escalating up the diet. It's very important. But this applies to mild pancreatitis. In severe, excuse me. So in severe, they are recommending enteral nutrition. What do we mean by enteral? So NG tube feeding or NJ tube feeding are actually comparable. There was a lot of conflict. They were saying NJ is better. Some were saying NG is like not accepted, it is old school. But the guidelines are actually clearing some air around this concept. They are saying NG is equivalent to NJ feeding. Caveat being if somebody is really sick and he's like intubated or something, you definitely are not going to do nasogastric because there is a possibility of aspiration. But both of them are comparable. None of them is better than the other. So NG or NJ feeding in severe pancreatitis, please use the enteral route. Don't use parenteral route. There is no need to give TPN and all that stuff. There is no advantage. In fact, you hurt the patient. How do you hurt the patient? Excuse me. If you give gut rest, you are going to cause mucosal atrophy. The bacteria from the gut are going to translocate from the gut, and actually they will make the patient sicker. So don't do it. So if you are giving somebody total parenteral nutrition, their gut is at rest, you are increasing the chances of having infection by this translocation of bacteria and causing the atrophy. Oral feedings have been shown to decrease mortality and morbidity. They have a shorter hospital stay, that's what the studies are showing, and there are no infectious complications because you are not causing atrophy, you are not causing translocation of the bacteria. So very important concept. And I think the same thing is written here that all these NG feedings, they maintain the mucosal barrier and prevent translocation. So it's okay to feed them. Yes, through the atrophied mucosa. Because their gut is going to be at rest, their colon is full of bacteria, it's going to be at rest for 7-8 days. That's what the conventional concept was, that you give them rest for 7 to 8 days and don't feed them. As a result of that atrophy in that colon, it's full of their own bacteria and it will translocate into the blood. So we are going to end them in sepsis and bacteremia. I think these are mostly my questions. These are the 8 concepts. I found them difficult. In my residency, I always had to struggle with them, but I think I just tried to clear the basic stuff here. And these are my references. I've used UpToDate, MKSAP 16 for questions, ABIM, but I manipulated the questions a little bit. And these are the guidelines, please follow. For pancreatitis or any GI problem you have, go to ACG site. They're pretty good at it. That's it. Any questions? Thank you. And I'm sorry, I was a little short of breath. My minute ventilation is high these days, as you can see.